So today's topic is amenorrhea. Amenorrhea is either physiological or pathological. It is defined as the absence or abnormal cessation of menstruation. Can be physiological amenorrhea or pathological amenorrhea. The causes of physiological amenorrhea is puberty or in young girls, before puberty, in young girls, pregnancy, especially in women of reproductive age, and postmenopausal in elderly women. Pathological are primary amenorrhea and secondary amenorrhea. This is very important. Primary is when there have never been any periods. Secondary is once there are menses and they cease, then is secondary. What are the various events of puberty? There is thelarchy, that is the breast development. It requires estrogen. Then there is pubarchy or adrenarchy, where pubic hair development occurs and it requires androgen. Then there is menarche or initiation of menstruation. It requires GnRH from hypothalamus, FSH and LH from pituitary, estrogen and progesterone from ovaries, and normal outflow tract. If any of these things are abnormal, then there may be problems in initiating the menstruation. So hypothalamus, pituitary, ovaries, and outflow tract, including uterus. Now coming to the primary amenorrhea. Primary amenorrhea is the failure to start menstruation by the age of 15 years in a girl with normal secondary sexual characteristics, or by the age of 13 where there is a failure to develop secondary sexual characters. This is very important. If the sexual characters are normal, then you can wait up to 15. That is, there can be physiological delay. But if secondary sexual characters are not normal, then by the age of 13, you should be alert and start investigating the cause of amenorrhea. Secondary amenorrhea is if menses are established and have ceased for longer than 6 months without any physiological reason, then that is secondary amenorrhea. Normally, the menstrual cycle is an orderly progression of coordinated hormonal events in the female body. Coordinated events are hypothalamic pituitary ovarian axis that stimulates growth of a follicle to release an egg and prepare a site in the endometrium for implantation if fertilization should occur. Menstruation occurs when an egg released by the ovary remains unfertilized. Then there is menstruation. If it becomes fertilized and implanted, then there will be pregnancy. Regular and predictable menstrual cycles occur if the ovarian hormones estradiol and progesterone are secreted in an orderly fashion in response to stimulation by hypothalamus and pituitary. Amenorrhea is a symptom. It's not a disease. Please do remember this. Amenorrhea is a symptom. It's not a disease, and it has a variety of causes. And it may be part of many syndromes. Proper function of hypothalamic, pituitary, ovarian system is required for normal menstruation. This I am stressing again and again because this is very, very important. From hypothalamus, GnRH, from pituitary, LH, FSH, and from ovary, estrogen and progesterone. All these will result in shedding of the endometrium, which needs an intact outflow tract so that there is menstruation. The occurrence of menstruation also requires healthy and intact outflow tract. Consideration of the target organs. of these reproductive hormones, that is hypothalamus, pituitary, ovary, uterus, is helpful for identifying the disease process responsible for a patient's amenorrhea. So hypothalamus, GnRH, anterior pituitary, LH, FSH, activin and inhibin, they have inhibitory effect on the anterior pituitary. Estradiol, progesterone have stimulatory as well as inhibitory. So estradiol, when increases, has a positive feedback in the follicular phase and negative feedback in the luteal phase. Now coming to the hypothalamic disorders. When we consider the etiology of amenorrhea, first is hypothalamic disorders. Eating disorders. A minimum of 17% body weight is required for the onset of menarche and 22% of body fat for maintenance or resumption of normal menstrual cycle. Therefore, if there is bulimia nervosa or other defects of eating, then there can be amenorrhea. Exercise-induced amenorrhea. 6 to 18% of the women who are recreational runners may have amenorrhea. So exercise-induced amenorrhea is also there. Certain medications like phenothiazines, methyl-dopa, cimetidine, butyrophenones, and antipsychotic medicines may induce amenorrhea. Then stress is a very, very important cause for amenorrhea, chronic illnesses, and Kallmann syndrome. Now coming to the pituitary disorders. Hyperprolactinemia causes amenorrhea in certain females. 10 to 40% of the females with hyperprolactinemia present to their physician as amenorrhea. Then there can be isolated gonadotropin deficiency. For example, deficiency of FSH or LH. Then craniopharyngioma. It's a tumor of pituitary. They are epithelial tumors arising from the craniopharyngeal duct in the cellar or paracellar region. In thyroid disorders, hypothyroidism as well as hyperthyroidism are responsible for amenorrhea. In adrenal disorder, congenital adrenal hyperplasia and Cushing syndrome, they are responsible for amenorrhea. Certain vaginal anomalies like imperforate hymen, transverse vaginal septum, and vaginal agenesis, because outflow tract is obstructed, will result in amenorrhea. Then uterine anomalies, androgen insensitivity syndrome or androgen insensitivity condition can result in amenorrhea. Then Mullerian agenesis, Mayer-Rokitansky-Kushner-Hauser syndrome, where uterus is very small or absent, and there is agenesis of upward two-thirds of the vagina, is the second most common cause of the primary amenorrhea. Coming to the uterine adhesions, Asherman syndrome is the presence of intrauterine synecdoche or scarring, preventing the normal growth of endometrium, typically from a previous infection or over-enthusiastic endometrial curettage or endometritis can lead to amenorrhea. Then cervical agenesis, which is very rare, can also lead to amenorrhea. Certain ovarian disorders like gonadal dysgenesis, as it is in Turner syndrome, 45XO, ovarian insufficiency or premature ovarian failure can also be there, in which onset of menopause is before 40 years of age. Then chemotherapy or radiotherapy can injure the ovaries and can result in amenorrhea. Then ovarian insensitivity syndrome, which is also now known as Savage syndrome, is also a cause of amenorrhea. And very common cause you have heard of is polycystic ovarian syndrome, which can have either spells of amenorrhea or amenorrhea. Now coming to the pictorial depiction of what can happen where. In hypothalamus, hypothalamic hypogonadism can be there, where GnRH secretions are less. Weight-related amenorrhea, that is anorexia nervosa. In pituitary adenoma or Sheehan syndrome, there is necrosis of the pituitary because of the PPH, prior PPH. Then endocrine, hypothyroidism or hyperthyroidism. In ovarian compartment, gonadal dysgenesis, gonadal failure or premature ovarian failure or insufficiency, and PCOS or polycystic ovarian disease. Then in outflow tract, congenital absence of uterus and vagina, vaginal atresia, imperforate hymen, and Asherman syndrome. Now coming to the primary amenorrhea. What are the various etiological factors for primary amenorrhea? Outflow tract disorders like imperforate hymen. Imperforate hymen represents one form of failure of complete canalization of the vagina, which is very easy to treat. One cruciate incision and it is treated. Presentation is symptoms, primary amenorrhea associated with cyclical abdominal pain. If there is outflow obstruction, then cyclical abdominal pain is there, abdominal swelling due to hematometra, and urinary retention may also be there. On examination or signs, bluish bulging membrane at the introitus, which is the hymen, imperforate hymen. Then coming to the gonadal dysgenesis or Turner syndrome. This is a chromosomal abnormality where 45XO karyotype is there, phenotypically female, associated with streak ovarian tissue and primary amenorrhea. Presentation is primary amenorrhea associated with features of Turner syndrome, that is short stature, webbed neck, increased carrying angle at the elbow, and sexual infantilism. Shield chest also. Next is androgen insensitivity. If there is testicular feminization, this is a syndrome found in patients with XY chromosome but resistant to androgen. That is androgen insensitivity. Has a male karyotype, that is 45XY, with female appearance, phenotypically female and genetically male. Presentation is female appearance with normal breast development and external genitalia, primary amenorrhea, absent uterus, and gonads are testis. Therefore, these gonads have to be removed later on. Otherwise, there is a risk of malignancy. Hypothalamic failure is Kalman syndrome. It's a congenital disorder characterized by hypogonadotropic hypogonadism, unicoidal features, anosmia or hypoosmia, primary amenorrhea. It's caused by the defect in synthesis and or release of gonadorelin, that is LH releasing hormone. Anosmia is very characteristic feature or loss of smell. Now coming to the secondary amenorrhea. Secondary amenorrhea can be physiological. The most common cause of secondary amenorrhea in reproductive age is pregnancy, and this should always be excluded by physical examination and lab testing for pregnancy hormone or pregnancy test, because you should not miss when you are labeling a patient secondary amenorrhea. Pregnancy should never be missed. In secondary amenorrhea, again, there are hypothyroidism, Cushing's, adrenal tumors, ovarian tumors. These are the endocrine problems. Pituitary tumor, Sheehan syndrome, hypothalamic dysfunction. These are the higher center problems. Premature ovarian failure, PCOS, or surgical removal of the ovaries, or radiotherapy. Then in the uterus, Eshelman syndrome or hysterectomy. Now coming to the polycystic ovarian syndrome, PCOS accounts for 90% of cases of oligo or amenorrhea. Also known as Stein-Leventhal syndrome, the etiology is probably related to insulin resistance with a failure of normal follicular development and ovulation. The classical picture is amenorrhea, obesity, subinfertility, and hirsutism. Hypothalamic cause. Hypothalamic dysfunction is a common cause responsible for 30% of the secondary amenorrhea. It is more often seen as a result of stress, weight loss, and eating disorders. In eating disorders, anorexia nervosa is the most common problem. It may also be due to tumor, infarction as seen in Sheehan syndrome, thrombosis, or inflammation of at the level of the hypothalamus and at pituitary level. Pituitary causes are pituitary failure. It is usually the acquired type as the result of trauma, treatment of pituitary tumors, or infarction after massive blood loss, as is seen in Sheehan syndrome. Pituitary tumor may be hyperprolactinoma, which causes secondary hyperprolactinemia by pituitary adenoma, which causes secondary amenorrhea. Endocrine disorders may be thyroid disorder and adrenal disorder. Thyroid may be hypo or hyper. Cushing's disease at the adrenal level, they interfere with the normal functioning of the hypothalamic pituitary ovarian axis and present with amenorrhea. High level of thyroxine, as in hyperthyroidism, inhibit FSH release. Androgen secreting tumors of the ovaries also cause secondary amenorrhea. Anatomical causes. Anatomical causes are usually due to previous surgery in secondary amenorrhea. The commonest cause is hysterectomy, then endometrial ablation, then Eshelman syndrome. It's the damage of the endometrium with adhesion formation, mostly due to infection and over-enthusiastic curating, and stenosis of the cervix following cone biopsy. Then premature ovarian failure. Premature ovarian failure occurs in about 1% before the age of 40 years. Premature ovarian failure may be due to chemotherapy and radiotherapy, may be due to autoimmune diseases following viral infections, or following surgery for conditions such as endometriosis, where part of the ovary is also damaged or removed. Now coming to the assessment of the patient with amenorrhea. Proper history, elaborate history in fact, examination, investigations should be done, and pregnancy must be excluded in the secondary amenorrhea. A good history can reveal the etiological diagnosis in up to 85% cases of amenorrhea. Ask about menstrual cycle, that is age of menarche and previous menstrual history, previous pregnancies, severe, especially history of severe PPH, which is important in Sheehan syndrome. Then weight change, a large amount of weight loss, for example, in anorexia nervosa or severe exercises. Hot flashes, decreased libido is seen in premature menopause. Certain medications, which I told earlier also, may cause amenorrhea. certain contraceptives, associated symptoms like Cushing disease, hypothyroidism, previous gynecological surgery, or any chronic illness. So these histories are very important. Check for body mass index, that is BMI. It's very, very important in weight loss related amenorrhea. Blood pressure may be elevated in Cushing syndrome and may be elevated in PCOS. Androgen excess, hirsutism or virilization. In PCOS, hirsutism is present. In androgen producing tumors, virilization may be present. Then look for the secondary sexual characters. For the features of Turner syndrome, best examination may reveal galactorrhea. Galactorrhea is important because hyperprolactinemia can lead to amenorrhea. Then abdominal examination may tell about the hematometra and about the pelvic masses by pelvic examination. Inspection of genitalia, infiltrate hymen and cervical stenosis. Vaginal examination about blind vagina, vaginal atresia, or absence of the uterus. Absence of breast development or pubertal growth by the age of 30 is abnormal and requires investigation. Breast development, pubertal growth spurt, and adrenarche are delayed or absent in persons with hypothalamic pituitary failure. Now coming to the investigations in primary amenorrhea. There are certain blood tests, ultrasound, in pituitary adenoma, CT scan of the pituitary, karyotyping, and laparoscopy. So if site of disorder is hypothalamus and diagnosis is hypothalamic hypogonadism, then investigations like FSH, LH, and estradiol are very important and they are low. If pituitary adenoma is there, then prolactin is high and FSH, LH, and estradiol are low. If gonadal dysgenesis, as in Turner syndrome, is present, then FSH, LH are high, estradiol is low, and karyotype is 45XO. If there is absence of uterus, as in testicular feminization, karyotyping is 46XY, and progesterone challenge test is negative. As there is no uterus, there will not be any result of progesterone challenge test. In imperforate hymen or transvaginal septum, FSH, LH, estradiol are normal. Progesterone challenge test is negative. And on examination, either imperforate hymen or transvaginal septum or cervical agenesis, they are present. Now coming to the investigations in secondary amenorrhea. Once the pregnancy is excluded, progesterone challenge test is done. If it is positive, that shows that endometrium is functioning. Thyroid function test, FSH, LH, and prolactin level. The need for treatment depends on the underlying cause. Need for regular periods, the patient may need regular periods or may need fertility or trying to conceive or may need contraception. So according to the underlying cause and according to the need of the person, the treatment is given. For pituitary tumors, bromocriptine or cabergoline are given, or if it is a big pituitary adenoma, then surgery may be recommended. Androgen producing tumor of ovary, surgical removal. Testicular feminization is removal of gonads plus HRT. Turner syndrome, HRT. Imperforate hymen, surgical incision. Thyroid diseases, appropriate medical treatment, mostly hypothyroidism, then you need thyroxine supplementation. Eating disorders if present, the patient has to be referred to psychiatrist. For PCOS, appropriate treatment should be done, and that will again depend on need of menstruation or need of fertility, Asherman syndrome, breaking down of adhesions, and insertion of IUCD is required. If a patient is trying to conceive, the prognosis for women with confirmed ovarian failure is poor. If anovulation is there, they respond well with ovulation-inducing agents. In PCOS, ovulation may resume with weight reduction or ovulation-inducing drugs or use of gonadotropins, and very rarely ovarian drilling. In hyperprolactinemia, they respond to dopamine and agonist, as I told you, bromocriptine and cabergoline. Nowadays, mostly cabergoline is used. Hypothalamic dysfunction, maintenance of normal weight, and change of lifestyle is required, especially in anorexia nervosa type of thing. For Asherman syndrome, I have already told you, breaking down of adhesion and insertion of the IUCD. Now, if a patient needs regular periods, then combined oral contraceptive pills can be used, or if near the menopausal age, then HRT. If there is need for contraception, then oral contraceptives are the method of choice. Thank you very much. If you have questions, please ask. Hello? Hello, students.
Yes, ma'am.
If you have questions, you can ask.
No, ma'am.
So could you understand that amenorrhea is physiological as well as pathological? It is primary as well as secondary. The causes are mostly same, but some may be different in primary and secondary. And treatment is according to the underlying cause. Once again, thank you.